Our Evidence Dialogue series is a quarterly webinar focusing on evidence for the effectiveness of different approaches in international development. We hope this series will help to foster deeper engagement within the evidence and policymaking communities. We hope you enjoy listening today, and we invite you to participate in the discussion. We'll have a couple of opportunities for you to pose questions in the Q&A function. Today's webinar will focus on the research and policy implications for teaching critical thinking about health. For this today, we're privileged to have colleagues joining us from the research and policy communities from 3 countries, from Kenya, from Uganda, and from Rwanda. Before we get started, a few notes on our agenda and on housekeeping today. We'll begin this morning, this afternoon, or this evening by kicking off with a brief overview of the concept of critical thinking by Andrew Oxman. Andy is the research director at the Center for Epidemic Interventions Research at the Norwegian Institute of Public Health, based in Oslo. After that overview, we will then have a presentation of the research findings by Michael Mugisha. Michael is an assistant lecturer at the School of Public Health at the University of Rwanda in Kigali, Rwanda. After Michael's presentation, our participants today will have an opportunity to ask questions of Michael and of his co-authors about the research. When that time comes, please use the Q&A box on your Zoom window for questions and not the chat function. After the presentation of research, we'll then have a panel discussion chaired by Nelson Siwankambo and Margaret Kaseje. Nelson is Professor Emeritus at the College of Health Sciences at Makerere University in Kampala, Uganda. Margaret is a Professor of Health Policy at the Tropical Institute of Community Health and Development in Kenya. Joining Nelson and Margaret as panelists, we will have 3 experts from the policy community. Jane Njuyu, who is the Principal Deputy Director of the Kenyan Institute of Curriculum Development in Nairobi. We will also have Grace Bagunma, Director of the National Curriculum Development Center in Kampala, Uganda, and Florian Rituyomba, Director of Arts and Humanities Curriculum, the Teaching and Resource Center Department at the Rwanda Basic Education Board. The full and impressive bios for all of our speakers are available at 3IE Evidence Dialogue's website, and the link will be in the chat. I invite all of our participants to take a look. To all of our panelists, we welcome you and thank you for being here today. A couple of last housekeeping notes. If our event is disrupted due to any reason, any technical reason, we will shut it down and reach out to you by email. This event is being live streamed on YouTube and shared on social media. If you're joining the event via live stream, please leave your question in the comments box. Finally, we encourage you to tweet any questions, points of view on X. Please tag @3IE News while you tweet and use #EvidenceDialogues. And with that, to begin, I would like to invite Andy Oxman to set the stage by giving a short introduction on the concept of critical thinking. Andy?
Thanks, Tom. So I'm just going to say a little bit about critical thinking and how we've approached it in the work that we've been doing. As many of you know, I'm sure, the advocacy for critical thinking dates back thousands of years across most cultures, although it hasn't always been called critical thinking. And it's been argued for at least 100 years that we should be teaching critical thinking in schools. It's been defined, critical thinking has been defined in a lot of different ways, and it still is. The definition you see on your screen now came out of a Delphi consensus process about 35 years ago with 50 critical thinking experts in the US. It's a mouthful, and I'm not going to read it. There's just the first sentence of a very long explanation of what critical thinking is. I prefer this definition, which is the definition that we've been using in our work, which Michael will tell you about in just a couple of minutes. Critical thinking is reasonable, reflective thinking focused on deciding what to believe or do. In the work we've been doing, we've also focused quite a bit on concepts. And this can be taken back to Dewey, who wrote about 100 years ago. It would be impossible to overestimate the educational importance of arriving at conceptions. That is, meanings that are general because applicable in a great variety of different instances in spite of their difference. Without this conceptualizing, nothing is gained that can be carried over to the better understanding of new experiences. We started developing what we call the Informed Health Choices Key Concepts in 2013 as part of a previous project funded by the Research Council of Norway. The concepts are principles to help people decide what to believe about the effects of doing something for our health and what to do. They can help us recognize unreliable claims about the effects of interventions, recognize reliable evidence, and make well-informed choices. The first published version included 32 concepts as a framework for deciding what people need to learn to think critically about health interventions and what we should focus on in the educational materials we were developing. We updated the concepts yearly based on feedback and experience using the framework up until 2019, when there were 49 concepts. In 2022, the last version of the framework was produced, and there were no new concepts or major changes. In addition to the explanation for each concept, we've included illustrative examples and the logic and evidence that are the basis for each concept. Sorry. Most of the concepts are relevant across at least 14 fields. We came to this conclusion when we had a consensus meeting with people from these different fields and went through the IHC key concepts and agreed that nearly all of the concepts could be applied to other types of interventions. The development of the concepts was also informed by a review we did of other relevant frameworks, including 4 frameworks for critical thinking. And as you can see in this Venn diagram, naturally, critical thinking is much broader than what we've been focusing on, where we focus specifically on assessing claims about the effects of interventions and making decisions about what to do. Other frameworks, critical thinking frameworks, and the IHC key concepts framework overlap with other types of frameworks, including frameworks for logic and argumentation, cognition, scientific thinking, and evidence-based practice. Our review of these frameworks also informed revision of the IHC key concepts framework that we've been using. So you might ask, why focus on health and questions? Why focus on questions about effects and choices about what to do? One reason for focusing on health is that it's important for everyone. Critical thinking can't be taught abstractly. Teaching the key concepts in relation to health interventions can also help students to think critically about other types of interventions. A reason for focusing on effects and choices is that what we do, both as individuals and collectively, can have important impacts. There are, of course, many things that affect our health that we can't do anything about. And most of what we do every day, we don't think about, and we don't need to, because it does not have important impacts on our lives. But some things we do or can do have important impacts, and thinking critically about those things can reduce unnecessary harm and waste. In addition, critical thinking also can reduce susceptibility to all the misinformation that engulfs us and reduce unnecessary waste and harms caused by misinformation about the effects of things we can do. There's one girl in a school where we piloted the Informed Health Choices primary school resources that we developed said, it is about things we might actually use instead of things we might use when we're all grown up, and by then we'll forget. More information, including publications about the IHC key concepts, can be found on our website, informedhealthchoices.org. Thanks. With that, I'll hand back over to you, Tom.
Okay, thank you very much, Andy. We'll now move from the broad concept of critical thinking to a very interesting application and very interesting research findings from Rwanda, Uganda, and Kenya. So, Michael, I will pass the floor to you now for a presentation of the research findings. After Michael speaks, we'll have an opportunity for questions for him and for the other researchers on the team. After that, then we will transition to a panel with policymakers. Michael, go ahead.
Hello, everyone.
Hello, Michael. Thank you.
Can you see my screen?
Yes.
I hope. Okay, thank you so much. Thank you so much. Now, moving on to just what Andy said on the work of the Informed Health Choices. My presentation is going to focus on the development and evaluation of the Informed Health Choices secondary school intervention that we did over a couple of now, I think 5 years. And what we are trying to do, we are trying to teach critical thinking about health to secondary school students. And our presentation is going to focus on what we have found. Countries. Faith was from Kenya, and Matt Oxman, who led the development from Norway, and myself in Rwanda, and Ronald from Uganda. We are all PhD students doing this work. Let me start by trying to shed light on the problem we're trying to address. And the problem is that we are flooded with a lot of information in general and health information in particular. And most of this health information we receive in everyday communication between one-on-one or in media or in magazines or in whatever other media and communication channels people can have. We always face what we call claims, what people tell us or advise us to do or to use for us to improve our health. And when you think or you begin to think critically, most of this information may not be reliable. And some of the information may be, of course, misinformed, may lead to misinformed decisions, or to some extent may lead to harm people, and also you may end up wasting resources on treatment claims that may not be necessarily relevant or even effective. Began to develop the intervention and tailoring the intervention of teaching young people to think critically. And we began our work with the primary school interventions. And this is where our secondary school intervention was built or built from. So as you can see from this picture, this was a comic book that was developed to try to teach primary school kids to make the informed health choices. And so then our work with the high school students, we began by understanding the context. What was the context of teaching the high school students to think critically? And our main overarching question was whether teaching the informed health choices key concepts was really a need in the high school. And if so, we wanted to develop digital learning resources, and we are interested to understand the landscape of ICT in high school. Led us to understand the context of ICT conditions and teaching and learning of informed health choices and critical thinking, in particular in high schools in the East African region. After understanding the context, we then prioritize the key concepts. As just Andy mentioned, we have a couple of concepts, about 49, and not all these concepts would be taught in high school, or there was no sufficient time to develop those resources, and based on 49. Then in collaboration with curriculum developers, students, and teachers, we are able to prioritize 9 key concepts that were felt relevant and easy to understand in the target age group of high school students. And these concepts were grouped in 3 categories, broader categories, as we have all the concepts in broader categories. Then the six of them were in the category called thinking critically about claims. And basically, I won't be able to maybe to mention all these 6, but they teach people to try to consider what people say and some of the aspects they consider in claiming, which may not necessarily be true. Then the second group of concepts had 2 concepts, was trying to teach people to about comparisons, in that evidence based on comparisons and based on research that is done in a small size of the sample would not necessarily make the evidence to be reliable. Then the last group of concepts, which is making smart health choices, we are trying to teach people to consider benefits and harms and costs and other advantages and disadvantages before an individual makes a choice, but also considering community choices. You need also to consider the benefits, the harms, the savings, and the cost associated with whatever choice you are making. So in brief, these 9 concepts were felt by our team and curriculum people in the East African students as relevant and easy to understand to the high school students. So based on these concepts, we then began the development work of the learning resources based on those prioritized concepts. And then our key overarching question was, how could we develop the learning resources that will be felt by students and teachers and the curriculum team as useful, but also as relevant to their context, as well as easy to understand and go through by the learners and the teachers. So to do so, we applied a human-centered design approach. This is a common design used in the design of products and resources. And we engaged key stakeholders, teachers, students, and curriculum developers and education authorities in different networks. We constructed networks in East Africa, Kenya, Uganda, and Rwanda. And then we developed together with them these digital learning resources based on the concepts we had prioritized. So the development work underwent a series of iterations where we began by generating ideas, and then we make a prototype. We could collect feedback from these networks and analyze the data from the networks, and then we check with the stakeholders and then come up with a working prototype. So we went through these rounds 2 times, and the 3rd time we came up with a final a product of resources that were able to be taught to high school students. Then now that we have developed the learning resources in the process, we had also to think about the teaching strategies that could be employed in teaching these concepts to high school students. And based on a systematic review of different teaching strategies that are there, we were able to prioritize some of the teaching strategies and use them in the design of the learning resources we developed. We ended up having the intervention that was depending on the ICT conditions in East Africa, Kenya, Uganda, and Rwanda. It was necessary to develop the learning resources that, one, were low cost, but also low tech in a way that required less internet and technology. And therefore, we ended up developing 2 sets of resources. One was Blackboard-based lessons, and the other one was projector-based lessons. And we also developed teacher's guide because in the context analysis, we understood that most teachers in East Africa were less experienced in teaching and learning of critical thinking. And then it was necessary also to think about how we could facilitate teachers as they developed and taught lessons that we had developed. The lessons we developed, we grouped them into 10 40 minutes lessons. And each lesson had to cover specific concepts we had prioritized. And then sometimes they could be reinforced in another lesson where time allowed. But the point was that within those 10 lessons, at least we could be able to go through the key concepts we had prioritized. Again, as I mentioned, we had developed the teacher guide, but also on the understanding we had from the context. It was clear that we needed also to train teachers to understand how they could teach these concepts. And we developed the training materials which we trained teachers before they could teach these concepts to high school students. The other question was also, now that we had developed the intervention, we needed also to develop a now
Michael, can you still hear us, Michael?
Hello, sorry, can you hear me now?
Yes, we can hear you now, and you're starting to share your screen again.
Yeah, sorry, there is a rain that is going on and internet is breaking off. Can you hear me now?
We can hear you now, but we cannot yet see your screen.
Great, thank you so much. I'm sorry for that disturbance.
Oh.
So I was saying, and after developing the intervention, we then began to discuss or think about how we could evaluate how the students were able to take or to understand the key concepts we had developed. So basing on the existing work that was done before on developing the outcome measures of assessing the critical thinking about health done by this group, we developed a critical thinking about health test that was actually testing the key concepts you had taught in class. And then we developed this outcome measure in a series of engagements, again, with the teachers and students, first by trying to understand how the outcome measure could be developed. I mean, could be whether it was understood by students, and also the questions were clear. In addition to that, we did a psychometric testing to understand to what extent this outcome measure could also be able to assess the key concepts we taught the students. Then we also tried to define the outcome measures that we had to assess in our trials. And the primary outcome measure was whether the student who had gone through these resources in comparison with the control were able to achieve at least 9 scores out of 18 on the critical thinking about health test we had developed. But we also had the secondary outcome measures on the mastery score, and that was defined by whether the student was able to achieve 14 scores out of 18, 14 and above. And then we also assessed the mean score and also the passing, mastery, and mean score for the teachers who participated in the trial. So then we ran the trial. These were parallel trials in 3 countries, in Kenya, Uganda, and Rwanda. And then that means we recruited at least 80 to 84 schools in each country. And then we randomized them in control intervention into 2 equal parallel arms. And then the intervention arm taught these 10 lessons after teacher training. And then the control arm just continued with the curriculum delivery without any intervention. At the end of the term, we assessed the effect of learning these resources. And then we repeated the same evaluation after 1 year. And in the next slide, I'm going to present what we found in our first evaluation after the end of the term. So overall, in 3 countries, the intervention was effective in Kenya, Rwanda, and Uganda, almost in equal percentages. In Kenya, at about 27% of students, most students passed the test. And same applies to Rwanda and Kenya. And the overall effect was that 32%, 32.8 more students had passed the test. And it was clear that the intervention worked. Then when you look at the mastery of the concepts, we also found overall that 18% more students in the intervention also had a mastery score. And when you look also per country, more students, 14 to 22%, also had a mastery score. We also assessed the mean score, and overall, in 3 countries, 17% more students had mean score. And we also assessed with the teachers, and 32% more teachers had a passing score. and 72 more had a mastery score in intervention arm compared to the control, and the mean score 32.5 among the teachers. So after the trial, parallel to the trial, we also conducted a process evaluation. And the process evaluation, we designed it alongside the trials in 3 countries. And our intention was to try to understand what could be the factors that could facilitate the implementation of the intervention, and those that could potentially facilitate the scale-up of the intervention. We are also interested in understanding some of the factors that might impede the implementation of the intervention. And what we have found across the 3 countries was that some of the factors that facilitated the implementation included teacher training, the fact that we trained teachers before delivering the intervention. It was a critical factor that facilitated the effective implementation and delivery of the intervention. But also the way the resources were designed in close collaboration with end users also facilitated the intervention. But also the fact that the intervention was felt by users as a valued asset was also one of the key factors that facilitated the implementation. However, it was evident that the schools had inadequate time to dedicate these resources or this time to teach these resources. And the fact that the lessons that were developed were not in the curriculum or not tested in national exams, it was also one of the limiting factors to observe the wider use. Another factor was also lack of printed materials. Of course, as you had also learned from the context analysis, schools had low ICT implementation, few laptops, and it was clear that for the resources to be effectively used, they required actually enough printing materials as well. So after 1 year, we also conducted the same evaluation as we did after 1 term. And we've also found that after 1 year, 25% more students in intervention had passed the score, had a passing score, and the retention was at 88.3. Similarly, also 12% of students mastered the score, and the retention rate was at 77. So we are also interested in understanding the transfer and adverse effects, what extent what we thought were able to be transferred by the learners. And we are also interested whether the intervention had any adverse effects. And we also looked at different factors that we had developed in a framework to understand the adverse effects following educational interventions delivery. And one of the factors were decision-making harms. That means behaviors and beliefs that might contribute to poor choices, and also psychological harms, more or less uncomfortable thoughts and feelings by the participants, and equity harms and inequities in the distribution or size of the effects. Another one was group of adverse effects was group and social harms, usually harmful interactions among the participants and their close people, but also the waste, which was more on the waste of time and resources. So what we have found on the adverse adverse effects and transfer, for instance, here we asked how much participants felt that the intervention was useful. And what we found is that a number of students felt that this they had used the intervention a lot, and some a little and very few not at all. We also interested in understanding whether what the students learned, if the students felt that when they challenge their teachers or when they challenge their parents or adults at home or their fellow students, how they felt. And as you can see from these findings, very few students, like 20% or less across in 3 countries, they felt bad or very bad when they had to challenge what the teachers said. Same applies to more or less 30 and below students. They felt bad or very bad when they had to challenge parents or other adults at home. Same applies to their fellow students, more or less 20% across countries felt that they didn't feel good when they had to challenge their fellow students. We also asked teachers whether they had observed any of their students relying on any of the unreliable claims that were used as examples in the lessons, because that would be an adverse effect. And most of them, they said rarely or not at all or sometimes or a lot. So it was 50-50 in a way. So after learning this, there are some implications we get from what we found. So one, adolescents in secondary school in low-income countries with limited resources, we found that they can learn these valuable skills. And what it means, this could also reduce the susceptibility of misinformation about health intervention, which is common. And it was clear that there are different inequities you could find in our trials, especially the learners who had low English proficiency, did not do well with the intervention. Same applies students who, small classes versus big classes, and also the fact that the teacher training focused on strategies for supporting students who need additional help. So when you look in general, these inequities, you may try to attribute it to the existing educational inequities or education system inequities we found or that are there existing. And teaching such a concepts in high school, we may not go without, or we may not miss experiencing such inequities. But definitely this should also be thought about and be considered as people may want to teach such a work in different contexts. The other implication is on the potential adverse effects. It was clear that there were conflicts because students tried to challenge claims made by people, but also some students may misinterpret unreliable claims, especially those used as examples. And this should be addressed by during the teacher training to ensure that teachers may be taught or may be advised on how the students could engage with their peers and elders in challenging or not allowing what others are saying. They should be able to understand how they should be engaging them in a non-confrontational ways, other than emphasizing on claims used by, and also not emphasizing on claims used in an examples as examples in the lessons. we could also say that the intervention was effective. It's freely available online, but to be able to scale these resources, people need to think about testing it out in different contexts other than East Africa, if it is going to be implemented in East Africa. But also it was clear that to be able to really realize the meaningful impact, the resources would be better be incorporated in the curriculum and also be examined in the national exams. It was also clear that human-centered design could help in developing resources felt by the users as effective, and children could start learning such concepts as early as the age of high school, and potentially this could also be reinforced as people try to teach them in a phased way from early years to later on to older years. So these resources could be, and all what you have done could be accessed on this website, and more information you can get it in this on this website. Thank you so much for your time, and I'm open to answer any questions together with my team. Thank you.
Thank you, Michael, for an excellent presentation. We do have a number of questions in the Q&A box, and I would like to encourage our researchers, Andy, Michael, Margaret, and Nelson, to address any of them directly in the box if they are easy to address, if you would like. But I will group questions that we have so far into two categories. The first are quite directly about the research, how it was approached, and the second are more about either longer-term outcomes or the other policy implications for the research. So let me put these to you as the researchers, Andy, Michael, Margaret, and Nelson, in a couple of groups. First, I'm going to tick off some factual questions. What was the age group of the students? How long was the training? How were teachers chosen? Could you give a quick sense of some sample questions? And then on the modules themselves, is it possible to teach the later modules first, or do they build on each other, and is that necessary to do them in order? So perhaps some quick responses to those, and then we'll get into the meatier questions about uptake and longer term implications. Michael, do you want to field these first?
Michael, do you maybe want to stop sharing your screen?
I have lost Michael again, Andy. Perhaps if you could tackle some of these questions.
Yes, please. Thank you. So,
triage.
Sorry, I didn't hear all the questions, but what I had was on.
Michael, we've lost you again. It looks like you might be on mute.
Why don't I give a few responses and the others can chip in while we're waiting for Michael. So the age of the students was 14 to 16, and the way that we recruited schools to the trials rather than teachers, and we randomly selected schools to try to get a representative sample of schools in each country. And then the principal in each school chose the teacher that would teach. We only implemented the lessons in one class in each school. Tom, were there other questions in that bundle that were factual? Oh, the questions that we used. So we used multiple choice questions from a database that we developed previously. The questions were all had face validity based on expert opinions. We used cognitive interviews to make sure they were understandable to the students, and we used rash analysis to validate the results. I put an example of a question in the Q&A, and the full questionnaire is available in the supplementary material in published trial results and the meta-analysis of the trials.
Okay, thanks, Andy. Let me move to a second batch of questions then. First, a question regarding whether there's been any attempt made to measure student decisions in real life, in quotation marks, as opposed to answering questions, or if there are plans to go back to the students later, sometime later, to see if they are making better decisions in the future. And then two questions regarding the policy implications. One, whether the research was designed as a project from the beginning, a research project from the beginning, and second, how it was conceptualized and implemented to ensure that policymakers would have the opportunity to integrate the results.
I can try and answer about the policy. We are actually going to, in our next few minutes, we're going to be talking to some of the people that were engaged from the government side. And that was one way to try to make sure that at the very beginning, the policy people would be engaged in the process. And we'll be talking with them in a few minutes to see whether that really happened and what the plans are for uptake.
Thank you, Margaret. And Nelson, you have your hand raised. Anything to add?
Yeah, let me comment on the practical question in terms of evaluation, whether there was some practicals, so to speak, in the evaluation. It wasn't. This was answering questions, but those questions had some practical elements in them, and even during the teaching itself. For example, the students had opportunity to give examples from their real life about the claims that they had had, whether in the families, whether in the school, and some of those, really showed some practical issues which they faced in terms of assessing whether these were reliable claims or not. In the interest of time, I'll leave that there.
Thanks, Nelson. Anything else, Andy or Margaret, you wanted to add to that round of questions? Any plans for follow-up later?
Yeah, I can add to that. So in the 1-year follow-up, we included self-reported questions to the intervention schools about whether they used what they learned or not. And we also included in both the intervention and control schools, asked them to report a claim that they'd recently heard and then evaluate it. And those data haven't been analyzed yet. The other way that we tried to evaluate whether students were using what they learned was in the process evaluation. We evaluated it qualitatively, and most of the students indicated that they were using what they learned in their daily lives.
Thank you for that. And again, I would encourage our research team to respond to any questions in the Q&A as they have the opportunity to do so. We're going to move now to the panel discussion, in which Nelson and Margaret will co-chair. And just a reminder again that on our panel, we're joined by Grace Baguma, the Director of National Curriculum Development in Uganda, and Florian Rutiumba, Director of Arts and Humanities Curriculum in Rwanda, and Cyril Oyuga from the Curriculum Center in Kenya will be joining us as well. So Nelson and Margaret, over to you.
Thank you very much. So I'll start off by asking maybe two questions. And please, the panelists, feel free to start with your answer if you want to be the first one on the question. So my first question would be that based on this study result, which you have had, do you think that at a country level, we are ready to actually scale up these interventions across the country or across a region? Or do you think that we still need...
Hello, Prof. Hello, Prof. Am I hearing you well? I think we've lost you. Hello?
Okay, let me repeat myself.
Hello?
Do the others hear me?
Now
Yes.
I can hear you.
Yes, we can hear you, Nelson.
So based on the results that you've had presented by Michael, do you think our countries or any of the countries is ready and would like to move to scaling up the intervention across the entire country, or there is some
Yes,
more
can I start? Yes, I think from the results and the way the research was carried on, I think the countries, especially Uganda, we are ready to scale up. And what do I mean by ready? These results clearly show that learners improved their ability to think critically about health choices. And therefore, with that behavior change, this is good evidence for our country, especially Uganda, to scale up. And of course, scaling up has a lot of implications, especially at the secondary level. We need to look at how do we build the capacity of teachers and the instructional materials for children to be able to have a countrywide scaling up, and it certainly will involve some cost, but we can have strategies on how we can create phased scaling up, for example, starting with the children in the urban areas and or rural areas, wherever the magnitude is high, depending on the study. And we see that children can begin to have a behavior change in informing their health choices, both in their communities where they live, but also at the school. So this is possible. We just need to come up with a detailed action plan and strategy so that, first of all, at the curriculum level, when an emerging issue like this comes, we develop what we call supplementary materials that go hand in hand with the training of teachers, so that when they are writing their lesson plans, they are able to use what the career topics are in the curriculum as an infused approach. I submit for now, Prof.
Thank you very much. The colleagues from Rwanda or Kenya, you want to add something to that? Cyril or Florian?
Hello.
Yes, please
This
go
is
ahead.
Florian.
Mhm.
Florian from Rwanda Education Board. Following the results, the findings from the researchers Mike has just presented, there is no doubt that critical thinking and research is always very important. And from again the findings we have just had, the scale up is again needed, because by having these students, you know, having this my critical thinking mind, and they are actually the agent of change in the society. So we really need the scale up, and I think since the resources that were developed were mainly digital and their own websites, I think at first there will be no cost. Maybe cost would be maybe on training, but resources can always be accessed digitally. And what we may need to look at is how to scale up, maybe starting with schools, with internet and computer, and then with the time we see how we can have other materials, printed materials, to scale more, to scale the program to more schools. So I feel the project is very important, and we really need the scale up. And having these children equipped with this kind of mindset, as I said, they are the future agent of change in our community. Thank you, and I submit.
Thank you very much.
Over
How
to you,
about
Prof.
from Kenya, Cyril? What is the thinking in Kenya? Cyril?
Michael, sorry, Nelson, we had word.
Excuse me, can I come back?
Please do. As Cyril tries to come in.
All right. So I was also of the view that the scale up could be done when teachers and students are still fresh with the training they had, and so the continuity will be much more easy when we have that continuity, other than waiting. So to me, I think it is important that the scale up switches on immediately. Yeah.
Thank you very much. Has Cyril joined?
I think he has not. I don't think he has managed to join.
Okay, that's very unfortunate. But let me pose a short question, which is a rider to the responses that we've had. So starting with Rwanda, because you've said the scaling should really start like now when the teachers and students are still fresh. So has Rwanda made any attempts in planning for scale up? And if so, what are those steps you've taken?
So far, not yet. On that, we have it in a kind of cost-cutting issue and a kind of generic competence in our national curriculum. But and teachers have always been reminded to talk about health issues, but when we have it in a more broadly and in a way that is emphasized, I think it can bring more results than teachers doing it at their own pace and in their everyday teaching. But if we have it as a separate and a reminder to all teachers, I think it will have the impact will be more high.
Thank
So
you.
we have, thank you.
Thank you very much. How about Uganda, Grace? Are there any efforts being made for the scaling to start, since you said that this is very important to do the scale up?
Yes, Uganda is making efforts at the secondary level interventions by looking at the horizontal integration at the lower secondary, because the good thing, Uganda had already picked what we call generic skills, which embeds critical thinking as part of the skills and problem solving. And by providing teachers with the informed health resources as supplementary materials, with the guidance to include in their schemes of work and lesson plans. That's an effort that's being made, but it needs to be resourced so that we can develop those materials and also give the capacity of teachers. But at the level of vertical integration for the upper secondary, one of the subjects that we are looking at to replace general paper is contemporary education or contemporary studies. And our thinking is that contemporary studies will embed the critical thinking skills for informed health choices as one of the components or the strands to be learned. So to me, that's a very good opportunity. It is coming in timely when we are reviewing the upper secondary curriculum. But still at the lower secondary curriculum, we have not lost it. As I said earlier, we always have ways of doing a supplementary materials for teachers, or we can actually cause a corrigendum so that the career subject, which is mainly science here, can take it on. But the most important gap is the capacity building for teachers to understand the pedagogies and the concepts that should be transferred to the children. So there are two efforts so far, and I'm happy that if all goes well, we should be able to have this integration of informed health choices concepts in the curriculum. I submit.
Thank you very much. I'll hand over to my colleague, Mary Kaseje, to post the other questions. Margaret.
Thank you so much. Yes, thank you, Prof. I just want to ask one question. In this study, which was done in 3 countries, you heard that there was quite a strong public and private schools in the study countries. So my question is, what do you see as a strong public-private partnership to drive the agenda of including critical thinking in schools? You mentioned that resources, especially Grace mentioned that resources could be one of the issues in scaling up. But if one had a strong public-private partnership, probably that could be addressed. So what is the role? What is the role of the public and the private sector in critical thinking? And either Grace or Florian can answer.
Let me start.
Thank you.
Public-private schools have a big role to play because they are the biggest provider of secondary education, like here in Uganda. And therefore, if they come on board and appreciate the informed health, critical thinking and all that, I think with the involvement of private schools, one of the things that I was thinking about is levying a small fee within the school fees structure. And that small fee of even 1 shilling or whatever, it can be determined, would go towards support of informed health choices activities. And therefore, we would create the extracurricular activities to support the in-curricular within the schools. Because when you have clubs and the associations, and they are supported by a fee that is levied at the school fees level, it can be small so that it does not feel like this is a pressure on the parents. And that fee would go towards supporting the activities of the informed health choice. And then later on, It could be a bottom-up approach on policy. Let alone it can inform government, and a levy is put under the Uganda Revenue Authority, income tax or so whatever tax, a small fee is put and it is named clearly for informed health choices. And that would be a bottom-up approach, in my view, starting from the private providers, but informing government that you can levy a fee and have, for purposes of creating sustainability models. Thank you very much.
Thank you, Grace. I do not have any further questions unless Florian has something to add. If not, that is fine with me.
Well, maybe in terms of public-private sector relation and the publishers, I think we can allow, most of the time, government does not, cannot provide for all the interventions. But if we can allow publishers to design, to develop some materials, I think they can be used by schools. Like the Ministry of Education can look at it, approve or recommend for more improvement, but at least we have a material that can be used as supplementary materials and during the extracurricular activities. So at least we have like guidelines which will be used by teachers and students during the extracurricular activity or co-curricular activities.
Thank you.
Thank you.
I think you've also touched on policy, both you and Grace have touched on policy, and you are indicating that there are opportunities to integrate critical thinking even at the national level and within the national curriculum. Thank you.
Margaret, there is in the chat, I see that Dr. Cyril has joined, and he requests to give his comments. So probably let's let him give some comments. Cyril?
I think we're working in the background to try and get Cyril access to the panel, and we're not quite there yet, it looks like. So we are continuing to work on that so we can hear from Kenya. But in the interim, I was wondering if I could put a question to our hosts of the panel and to our researchers, and that's to think about the prospects for follow-up research. So we've heard so far some fairly intriguing comments from our colleagues who are policymakers. We've heard about enthusiasm for the results. We've heard an encouraging positive reaction to the prospects for scaling up. And in that context, I'm wondering about possibilities for future research, possibilities to see about the persistence of the treatment effect, possibilities for thinking about in enabling, and what are the enabling factors, and also possibilities for variation in treatment. I was very intrigued to see in the chat that we actually had one of the teachers, I believe, who had received the training, asking about the length of training and some sort of practical questions about how to get everything in a given module. So if I could put to you, and also our researchers, Andy and Michael as well, other researchers, what your thoughts are for the possibilities of follow-up research and how that might look and where you would take this.
Can I get started?
Yes, please, go ahead.
Yeah, let me give one research issue that is quite important. And that is equity, related to equity. If there's scaling up at a country level, we need to be sensitive to the issues of equity, because some schools do not have as much resources as the other, and the resources include teachers as well. And therefore, there should be research that continues to look at the issue of equity so that we can bridge the gap as we move along, so that the inequities become less and less. I think, to me, that is one of the very important questions. And you brought up a few others already, but my colleagues can come in. Over to you.
Go ahead, Andy.
Yeah, I think there's quite a few research questions that need addressing. One is designing and evaluating an effective implementation strategy for scaling up the intervention. Another is, Michael mentioned several in relationship to tweaking the intervention to reduce the adverse effects that we identified and to increase, well, as Nelson was saying, reduce inequities and to try to strengthen transfer use of what was learned. Probably most importantly is any one-off intervention for a single school term is going to have limited effects and limited retention and what's learned. And I think there's a major need to develop a spiral curriculum where the students start learning in primary school or even in daycare, and what they learn is reinforced in subsequent years, and they learn new concepts or competences or dispositions. And the challenge that's faced not just in East Africa, but around the world is curricula are so packed with things, a lot of which aren't all that useful to people, that it's a challenge to get anything new into the curriculum. And that's not so much well, I don't know how you would research that, and I really don't know what the solution is, but that's going to be the biggest challenge moving forward with this, or really any change to educational curriculum.
I just
ahead,
want to
Margaret.
add, yes, I just want to add that it has been hinted by Andy, but just the issue of sustainability, you know, what aspects can be sustained over a period of time. We know that the students retained some of the concepts and actually use them practically, but over, you know, a year, 2 years, 3 years, are these lifelong concepts that they will continue to use throughout their life or not? You know, we don't know. So I think probably further research to even crystallize the concepts even further, to, you know, to make them really clear on what is sustained over a period of time would be really interesting.
Excellent, and thanks, Margaret. And Michael, I see you have rejoined. Was there anything you wanted to add on the question of follow-up research?
Yeah, thank you so much. Sorry, there's a lot of rain here that interrupted our internet. So, I think I just want to reiterate what others just said. One could be to test more more concepts in the same way we did this, but also looking at how other different age groups could benefit more or less using the same intervention we developed. And all these would be other ways of doing the same work in the same school setting, but also thinking about other settings beyond school settings that would benefit same age group and also impact their ability to think critically. On top of my head, those could be the areas of future research and what could be done in the future. Thank you.
Thank you, Michael. We have a rich set of follow-up topics for research to flesh out the findings and to explore different ways in which they can feed into the policymaking process, which will necessarily involve trade-offs within the curriculum, as Andy highlighted. Before we go to a last couple of questions from the Q&A, I see that Faith has joined us, I believe, from Kenya. Faith, are you pinch hitting, or are you the substitute batsman for Cyril? Go ahead, Faith, you're unmuted.
Hello, can you hear me?
Yes, we can hear you. Is that Cyril?
That's Cyril, yes.
Yes.
I've been having a small
Yes.
technical problem. I'm now fully in. I'd like to just respond to a few questions, which, if you allow me, that were raised earlier. The first one was about the readiness to scale up in Kenya. Kenya is fully ready to scale up because critical thinking is one of the competencies in the current competency-based curriculum. And it resonates well with both primary, that is early years levels, and middle school as well as senior school levels. So I believe this is something that will only require a bit of validation and approval from the policy perspective. And then the curriculum will be integrated in the current competency-based curriculum, which is already ongoing. So that one will not be a major issue, only the final policy process that will enable this to be validated and approved by the academic committee. It becomes a policy issue. There were other questions which were raised in terms of preparations, things that we need to do in order to enable critical thinking in health choices to be included in the wider curriculum. The process will involve development of designs, curriculum designs, which are similar to the syllabuses, but more detailed. This will involve a scope and sequence approach to fit different levels. For example, the early grades in secondary school and the later grades in the middle school, where that competency fits. And the process will continue that way. There will be need to develop teacher support materials, and teacher guides, working together with the research team, because the research is already done, and the curriculum, therefore, will just be confirmed that it fits the requirements in the Kenyan system. And the development of materials will be both electronic materials and non-electronic materials, which is already developed by this team that were involved in this study. It's a matter of focusing and reintegrating the materials, and with the additional guidelines for teachers. Teacher training must be done briefly. Basically, it will be teacher capacity building to bring everything on board, to make and update the content, as well as all the other areas like the methods and so on that will be applied, because this goes very close with the competency-based curriculum. critical thinking is a major competence, one of the 7 competences in competence-based curriculum, and therefore there won't be a major issue. The only issue is to put the various learning areas at various levels and integrate this with other competencies and learning areas, because this curriculum is an integrated curriculum. We don't study health learning area alone, but you make it fit with other areas so that it's a real life experience for the learner. Both practical, more practical, theoretical, as well as putting in their values, the passion, the liking of that issue, that new area that's being taught or being brought into the syllabus, or in the curriculum. So I believe Kenya is ready for this, only to do a few checks and balances, and working together with the research team and the whole team that are involved in this. I think the process will go on well. We were already engaged, we already interacted with those who are in charge of the research from the beginning, and we've been moving together. I didn't introduce myself. I'm formerly a deputy director, research, monitoring, and evaluation at Kenya Institute of Curriculum Development. Right now, I'm retired, engaged in other consultancy work, but still working in those areas where curriculum CBC is involved. And so I came in because I started working with the team before I left Kenya Institute of Curriculum Development. There are other members of my team who also been working with me from the time the research study started. I'd like to stop there for now, and we'll receive more questions and issues and add more comments. Thank you.
Okay, thank you very much, Cyril, and you're most welcome. Thank you for joining us, and apologies for any technical difficulties. But before we wrap up, any last responses or thoughts, comments that any of the researchers or our panelists would like to make?
I just want to make one comment. Usually research is done and it's wrapped up, but I'm really happy to see that our policy influencers here from Uganda, from Kenya, from Rwanda are really ready to take up the results of this research, and that's very encouraging. Thank you.
Thank you, Margaret. Grace.
What I wanted to add is we need to put together to pull the resources, because I see still a huge task ahead. Because what was done by the research has shown us that there is a gap, there is something that is eating up the communities. So my belief is that it is not only in the schools, but we are also looking at the communities. What is it that can be a parent education curriculum or package that we can take to the parents? So we have the backward and forward linkage, the learners in school, but we have also out of school, but we also have communities. So the thing is huge, because we are looking at a behavior change, and therefore a number of other interventions or studies need to be done and action-oriented, such that the behavior of thinking that you can medicate yourself, you can take a decision on what to treat yourself with, stops, especially in us in developing countries. When you develop a headache, your mother tells you, or even a person you are with, go and buy a Panadol. Quickly the headache will go, and you run to the nearest pharmacy, and they don't ask for the prescription. So one of the things is also government to put a regulation. How do they control the access of medicine from the pharmacies, for example, and other herbalists? So there is a huge task, a task on how to triangulate and reach to as many members of the community as possible. I submit.
Thank you. I'd like to respond to that comment. In Kenya, what we have developed in the competency-based curriculum includes a major component, 2 major components that are already implemented in the overall curriculum. One of them is community service learning, which begins in the secondary school level. That is the junior secondary and senior school, especially senior school and thereafter. So this is part of the programs that learners are introduced to. So when they engage in community service, they go and work with the members of the neighbor communities, learn at the same time, and also enable members of the community to learn what they have learned together. The other aspect is parental empowerment and engagement. Parents are involved in this process from the beginning. So the element of health issues or health competencies, when I talk about critical thinking in health, this is going on or will go on with the support of the parents at home. And the child is able to think around and see what they need to do. They need to show the parents that they can decide on their own what is best for their health. And the parents support them. So this is an aspect that is already being developed as a major program in the overall competency-based curriculum. And I believe that's a very good comment in terms of developing the overall values that children or learners should have. Thank you.
Thank you, Dr. Cyril.
Hello.
Nelson.
Hello.
Let's go to Nelson and then Florian.
Very short comment. We have heard several times, many times, that if critical thinking, teaching critical thinking is introduced in the curriculum, but remains a non-examinable component in the curriculum, then it will be, the impact will not be as good as if it was made an examinable subject. I just put that challenge there. Maybe in the other countries it is the same. I don't know.
Thank you, Prof. I think when you have put something as an added or as part of the content of the curriculum, then it automatically becomes examinable, because then when you are setting the question papers, you can set on informed health choices. So what we need to kickstart is to make that to make sure that the intervention is upheld or integrated. And at that point, the moment it is captured as one of the areas that is learned, then automatically it becomes examinable. So that means that there will be need for revisions of the sample assessments to see that the examination bodies see that there are some new dimensions that require to be considered when exams are being set. I think that can be done, and it is possible. That is another area that we need to go into and focus on as an intervention. Thank you very much.
Thank you. Allow me also to add a comment on that in Kenya, the emphasis on examinations has been really reduced and instead replaced to a large extent by practical continuous assessment. That if a learner gains health competencies, critical thinking in health aspect, they are able to be assessed as they grow in practical approach, using a practical approach, and in a continuous way, where this continuous assessment that sees whether this child is developing those concepts, applying them, and using them to help others is important. There's the terminal examinations, what we call the summative examinations, that come at the end, but they do not account for all the measures of learner performance. They only contribute a very small part of what the learner is able to do in terms of assessment. So assessment approach has been changed. There's been a shift in the way measurement and evaluation is done, and therefore learners are made to emphasize more practical skills and values, as well as the aspect of knowledge together. So assessment will not focus only on the cognitive thinking. but what a learner can do practically and show by practical work. This is going on, and as one mentioned, as a question was raised earlier, there's going to be continuous monitoring and evaluation of various aspects in the curriculum, including the health, critical thinking in the health practices. This is not something that will end here. Every time the national curriculum inputs evaluations and monitoring studies to assess what these learners are doing over time. Thank you very much.
Thank you, Dr. Cyril. Let's go to Florian, and then Nelson will give you the final word.
Thank you very much. And may I start by thanking my colleagues, Kenya and Uganda, on whether this intervention should be examined separately. So my understanding is since the intervention is already integrated into the national curriculum, then what we need more is like when we will be training teachers. So we'll emphasize on how the assessment should be done, especially by considering the high order of thinking, and among them will be assessing the attitude and values. And in so doing, they'll be assessing critical thinking. So unless we have a separate subject, but otherwise we'll need like the supplementary materials and training of teachers on how to assess and teach when they are emphasizing on the intervention. Lastly, before I leave, I want to thank Mike and the team of researchers, how they worked hard to reach these findings, research findings. And so I would like to request that in most cases, when researchers undertake their project and they finish, they present the findings, and that in most cases they end by presenting the findings only, and it becomes end of everything. So my humble request to them is not to leave. Yes, they presented their findings, but we still need your guidance. We want you to be close to us, and we continue looking at how we can impact the future population of our countries. So please don't leave us. Thank you. I submit.
Thank you. Nelson, very quickly, as we've just gone over time.
With that comment, I really shouldn't add more. It's a very nice comment which brings researchers and policymakers to work together so that research results can have a meaning for people. I'll leave it at that and only say thank you very much for the comments.
Thank you, and I would like to thank all the panelists and add my voice to that characterization of the excellent example this is of bringing together research with policy, and also add my voice to the encouragement to stay engaged with the follow-up research as well. This really has enormous possibilities to make a difference in a critical area, both in terms of skill-based education, but also the behavior change associated with it, not only in health, but in broader areas as well. So thank you again to all our panelists. Thank you to the researcher. Thank you to the 3IE team for helping organize this webinar. The live stream of this video will be uploaded to 3IE's YouTube channel, in case you would like to share this webinar later. If you would like to continue the discussion on Twitter, please tag @3IE News in your tweets. You can also subscribe to email updates from 3IE by visiting our website, 3ieimpact.org, to learn more about future events and our next Evidence Dialogue series, and we hope to see you there. Thank you all very much. Good morning, good evening, and good night.